Welcome to Ready to Talk, Ready to Listen, a podcast about all things mental health. CHE Behavioral Health Services interviews guests as they discuss relevant mental health topics and speak with our industry's top leading trailblazers. Let's get started discussing behavioral health and ways to support our mental well-being.
This is Dr. Larkin Hoyt here, and I'm a practicing psychologist and the clinical director for CHE Caring Health for Everyone Outpatient Services. I'm your host of the Ready to Talk, Ready to Listen podcast, where we feature top experts and leaders and those interested in behavioral healthcare and mental well-being. I have Mr. Charles Westfall here from Sharp Mesa Vista Hospital, which is located in San Diego today as our guest. Welcome, Charles.
Thank you, Dr. Hoyt.
And I will be interviewing him about understanding suicide prevention and what are important things to know about when it comes to preventing this public health problem. What I'd like to also say is the title of this particular podcast, which I normally don't mention, but I think it's important, is Hold On to Hope. There is always help, understanding suicide prevention. And I think that really is going to be the message we want to continually thread through as we talk about suicide prevention, is that there is hope. This episode is brought to you by CHE Behavioral Health Services. CHE offers comprehensive mental health care solutions, including in-person and telehealth psychology and psychiatry services. Listen, Mr. Westfall from Sharp Mesa Vista Hospital, Americans are experiencing greater stress, anxiety, and depression than ever before. CHE's mission is to provide access to care and support people to improve their quality of life and their emotional well-being. We have over 850 professionals that are committed to providing gold standard care and evidence-based behavioral health care. To learn more about CHE or to book an appointment, please call us at 888-831-2618. That's 888-831-2618, or visit cheservices.com. So I know I already told the audience, I already gave a shout out to Mr. Westfall, but I'd love to formally introduce you, and I'm excited to welcome him today. The two of us have been longstanding colleagues together through the years. And what I'd like the listeners to know is that he comes with a wealth of knowledge and experience as it relates to all things mental health and suicide prevention. And so we're talking to Mr. Charles Westfall. What I'd like to also do, Charles, if you're okay, is give you a little bragging rights and talk quickly about your bio, or read your bio to the audience so they know who they're listening to. Is that all right with you?
Sure. Yeah.
Great. Okay. Mr. Charles Westfall is a practicing licensed marriage and family therapist and is currently the clinical manager of the adult intensive outpatient services for Sharp Mesa Vista Hospital. Sharp Mesa Vista Hospital is the largest provider of inpatient and outpatient behavioral health services in San Diego County. In his role, he sits on the Suicide Prevention Steering Committee, which is supported through hospital-wide initiatives that target zero suicides. In addition to his administrative and clinical roles, he is an adjunct faculty in the Counseling and Marital and Family Therapy Department at the University of San Diego. He currently serves as a board member for the Association for Ambulatory Behavioral Healthcare, focusing on best practices for hospital-based services, and just last year became the co-chair of the San Diego County Suicide Prevention Council, whose mission through a collaborative community-wide effort is preventing suicide and its devastating consequences in San Diego County. He received his bachelor's in philosophy from Purdue University, a master's in theology from Fuller Theological Seminary, and a second master's in marital and family therapy from the University of San Diego. Wow, Mr. Westfall, you're quite a triple threat.
Thank you. It's a lot of words.
Well, listeners, I have to say he obviously has come to us with a lot of experience, and he is volunteered to be a guest today so that we can shed some light on suicide prevention. And so, like I said, in this episode, that's exactly what we're going to talk about: how to prevent suicide and how to recognize risk. Suicide is a serious public health problem that can have lasting harmful effects on people, on their families, on their communities. The CDC reports that there's 46,000 deaths in 2020 due to suicide. 12.2 million adults seriously thought about suicide, and 3.2 million made a plan. Following that, those dire stats is that 1.2 million people in the United States attempted suicides. Also, something to chew on here is that suicide isn't necessarily specifically targeted at one particular area of development in your life. It is a problem that exists throughout the lifespan for all of us. For example, it's the third leading cause of death for youth from the ages of 10 to 14 years of age, and the second leading cause of death among people 15 to 24 and 25 to 34 years of age. And the fourth leading cause among people 35 to 44. And then again, the fifth and so on. And the eighth for people 55 to 64 years. And so, this is something that is not necessarily discrete to a particular cohort or age group. Like I said, it is something that can be experienced throughout our lifespan. And so we really want to understand both risk and protective factors that prevent or contribute to suicide. What also I think is important for our audience to understand is that that's no different than most public health problems, being that this is one. And what I'd like to say that we do throughout the episode is that we thread hope through the needle of understanding that suicide is preventable. And even more so why we picked this topic, I think it's important to share collectively as a society. It's important for us not to be afraid to speak up about suicide, to speak about mental illness, or seek out treatment for a person who's in need. That's why it's so important to start by eliminating the stigma associated with mental health, understanding why suicide occurs, and advocating for mental health awareness within our communities. And I really believe it's a responsibility, a collective responsibility for all of us. And we all have an opportunity to embrace that. And so even by you listening today, you're exercising that opportunity and that collective responsibility. So I do want to thank our listeners out there for tuning in. As more of our communities across the nation join this effort, more available resources to those that need it can be made accessible. Most communities promote local and national suicide hotlines, mental health support groups, online community resources, and many other mental health professionals can help people who are struggling with distressful, painful thoughts and emotions. One kind of pregnant pause before we pick Mr. Charles' brain. I think it's very important that we share some national resources for our listeners. So if you are feeling suicidal, please talk to somebody. If you or someone you know is experiencing mental health, suicide issues, or substance use crises or emotional distress, you can reach out 24 hours a day, 7 days a week to the 988 Suicide and Crisis Lifeline. This formerly used to be known as a National Suicide Prevention Lifeline, but now it's an easier way to access 24/7 if you are in a crisis or if you believe your loved one is in a crisis. So please, you can dial or text 988 to connect to a trained crisis counselor and get the support you need. You also could text the crisis text line through NAMI, which is a National Alliance of Mental Illness, at 741-741. And you can also use the Trans Lifeline at 1-877-565-8860 or the Trevor Project at 866-488-7386. If you didn't get all those numbers, it will also be reflected in our link. And I will bring it up towards the end of our podcast just to remind people that there is a national hotline that can help you or your loved ones or a coworker, whoever it may be, that may be impacted by mental health issue and or crisis. Okay, so Charles, Mr. Westfall, are you ready to kick off?
I am ready.
Okay, so before I ask you some questions, I think it's important for our audience to understand the definitions of suicide. So what I did some brief research to look at what the standard definition of suicide is. And this was found through the Centers for Disease Control and Prevention, aka the CDC, and is really part of a broader class of behavior called self-directed violence. Self-directed violence typically refers to behavior directed at oneself that deliberately results in injury or the potential for injury. Self-directed violence can be suicidal or non-suicidal in nature. But for the purposes of this podcast, we are going to refer only to behavior where suicide is intended. So that definition is that suicide is a death caused by self-directed injurious behavior with any intent to die as a result of the behavior. Now, we may also interchange suicide, death by suicide, or suicide attempt. So I will go a little bit farther and stretch and share that definition. Suicide attempt is defined as a non-fatal, self-directed, and potentially injurious behavior with intent to die as a result of that behavior. So a suicide attempt may or may not result in injury. So therefore, today, our intention is to promote awareness around this public health challenge. And like I said, we want to stigma bust and create a safe place where we can share stories and help promote awareness around suicide prevention. So let's start out by educating our audience about common myths around suicide, Mr. Charles Westfall. You have so many degrees, you should have doctor behind it while you're at it. So myth one, I've heard this is a myth. Can you tell us why and if it is? Suicide only affects individuals with a mental health condition.
That is a myth.
Okay. Right? Why is this a myth?
It's a myth because, well, it's true that many people who might experience suicidal ideation or have a suicide attempt might be struggling with a mood disorder or a mental illness. It's not the case that all people who die by suicide or who attempt suicide are dealing with a mental illness. There are individuals who've never been diagnosed, have never sought treatment, and find themselves in a suicidal crisis. And so it's important to not think about suicide as being a behavior that those people over there experience, right? We don't want to think about it as being something other than the self. And the reason why we want to think about this as being a phenomenon that could impact everybody is it reminds us again that this is something that we can help change, we can address it. It impacts everybody. And I appreciate your starting point with stigma, because if we identify it as being a process or an experience for people with a mental illness, then we can easily separate ourselves from that. And we don't want to do that. People have had suicide attempts, based on life circumstances. And I think we'll get into the complexity of suicide through the conversation. But there's legal matters. There might be financial losses, emotional or at least emotional responses to relational breakdowns that might lead someone into a place of suicide.
I think that is so important to highlight and bust that myth, because like you said, it is a public health challenge and we don't really want people to create more of an us and them, which
Right.
does promote more stigma. And that if we all can kind of understand that we all at some point in our lifespan could easily be at risk for experiencing suicidal ideation, then we're less likely to, push back or resist the idea and be a lot more compassionate towards others that may be experiencing it.
That would be the hope.
Okay.
Can I just say one more thing about that stigma? You were saying you were identifying the resources, and that 988 number that just came live this month is a really big deal as an example. And I guess it's probably in addition to the increased awareness of mental health concerns related to the COVID-19 pandemic about where we are. Like there is slowly this awareness that access to care is available and appropriate. And so I think we're going in the right direction, but we just need to continue talking about it and being open to these topics.
Yeah. And I go back to like the us and them. It's really more about the us. And I think that just echoing what you just said, by access and more awareness around mental health in general has helped that really kind of be something that it's not 10 degrees of separation. Often it's ourselves or even our closest friend or family member. It's like 1-to-1 almost, not 1-to-6, right? So that's important. Yeah. Okay, well, I have another myth I want you to see if you can bust for us. So this myth is once an individual is suicidal, he or she will always remain suicidal. Fact or myth?
That's another myth. Someone that might be experiencing suicidal ideation, we would identify that as a crisis. And crises don't last forever. There's circumstances that might lead someone to a place of significant stress, and in response to that, they might, their thinking might shift towards suicide as an option. But like any type of crisis or even actually an emotional state, we know that over a shorter period of time, that'll dissipate if things change. Now, there are circumstances where a crisis can extend for days, and people can ruminate and think about death and dying and not see a solution. But even still, that's not going to be for all times. There are people that struggle with chronic suicidal ideation, and someone with chronic suicidal ideation, it oftentimes presents still as an episodic experience. So stress happens, there's this onset of negative thinking and hopelessness perhaps, and then hopefully with intervention or some improved coping strategies, the individual will then reduce back down to a baseline. So it doesn't mean that just because someone has had suicidal thoughts or behaviors that they will for all time, because many people who have struggled with suicidal ideation, and even those who may have made an attempt, go on to live a meaningful life. And so I think it's important to say that just because someone has experienced that means that somehow this is going to be with them forever.
Right. I just to piggyback from that really important kind of statement, if you will, is the idea. There was a metaphor that I really like sometimes when it's important for us to know, like when we're feeling really bad and we're feeling really out of sorts, whether or not we have a diagnosable mental health condition or not. It's the metaphor is, the weather, feelings and thoughts are like the weather, they change. But you as the self, you as your own self is like the sky. It's always there. And that just what you just said, just kind of, I wanted to reflect on that for a minute, because I think it really is suggestive that these painful emotions and thoughts, even leading with extensive or chronic suicidal ideation, can be lifted and they can change and dissipate. How in which they, their frequency, their intensity, how often it comes on and for how long is going to be, different for every person, because each of us are so very different in our own right. But the bottom line message is that there is hope, and you won't always remain suicidal or feel this way.
I like that.
Okay, good. So I got it right.
Good. Yeah, you got it.
So how about the next myth? And this one I think is important, because I bet there's a lot of listeners out there, because at one point I would have thought that this was true. Now I know as a professional, but if I wasn't a professional, I'd really think this way. So tell me, myth or fact, most suicides happen suddenly without warning.
That's another myth.
That's good to hear.
Now, it might look like a fact, like you just said. It might look like it came out of nowhere. Someone might make a suicide attempt, and a family or friend might even ask themselves or think to themselves, I wouldn't have expected that. I didn't see that coming. And that might be true, but that doesn't mean, or at least doesn't follow from that for the individual that it's out of nowhere. And so there's oftentimes what we describe as warning signs, or some shifts in verbal or behavioral changes, what people are saying or how they're acting, that would precede probably a suicide attempt. And so it's important that there are things, which hopefully we can talk about today, warning signs that are associated with suicide. Doesn't mean that it's a script that people are going to do this, this, and this, and follow with the suicide. It's much more complicated and nuanced than that. But there are signs. Many people are careful with whom they might share those expressions of hopelessness or changes in behavior. So there's opportunity for us in relationship with people who are struggling to be aware, but they don't come out of nowhere. And oftentimes it's life circumstances along with a lot of other layers of complexity that lead up to that crisis.
Right, that makes sense. And I think again, just threading that needle of the needle of hope, right? That what I'm hearing and what I think the audience can take away is that even though the death by suicide can feel so sudden and so kind of abrupt in a loved one's life, there are opportunities prior to that, other people, not just survivors of suicide, of loss by suicide, but outside of that, there are opportunities for other individuals to start to recognize those signs. And that person may not be suicidal at that point, but the behavior shifts, and we'll talk about warning signs in a second, but the behavior shifts can subtly start. And that might be an opportunity to lead with compassion with the one you're concerned about and bring up a discussion or try to help them get access to care so that it doesn't necessarily result in a suicide or a suicide attempt. Okay, so next myth. People who die by suicide are selfish and take the easy way out. Now, I'm going to think most listeners are not going to agree with that and think it's a myth, but I still think there are some outliers out there, or people that are really, again, those that have lost people or loved ones from suicide can often, not to invalidate their feelings, can often feel that way when they've lost someone they love by suicide, and they feel that they're very selfish and that they took an easy way out and kind of left everyone, that they loved. So myth or fact?
Well, I think it's a judgment, actually. It's a myth that's not true, but I think it's actually an expression maybe of anger that someone might experience and not knowing what to do with that emotion. And so it's you took the easy way out as an expression. And I think it's a painful phrase. And I think it's a painful concept because from all of my experience thinking and talking with people about suicide, people who are suicidal are suffering so profoundly. And many people have the opposite view where they have such a low sense of self or a diminished sense of self that it gets inverted to where they think that their death would be worth more than their life, and which speaks more to their concern for other people and how much they care about people in their lives. And so I think it's more about, someone that dies by suicide is in a very dark place, might be extremely helpless and hopeless, not in a selfish place, but probably seeking relief, right, from that suffering.
Mm-hmm. Absolutely. You took the words right out of my mouth. Just to end, they want to end their suffering. They're they're tired. It's no different than how some people who are fighting cancer and they're in stage 4 and they've just gone through so many different treatments and chemos and they're just suffering so much and they just want to I'm done. I don't want to do another chemo treatment. I want to just end the pain. Mm-hmm. And I think it's important to draw that comparison sometimes between mental health and physical health, being that they're very similar in so many ways because they're both significantly important for the quality of our lives to be the best that they can be. And one doesn't exist without the other. And I think that it's important that we see also disease that's correlated with physical and or mental in that same vein. In other words, there's not as much stigma for someone going through an extensive, difficult cancer treatment as there may be with people who are going through an extensive bout of depression or episode of depression that has suicidal ideation as a symptom or experience. And I think that if, again, this podcast today, just talking about that and bringing up those comparisons and seeing, even though they're equally important, they're handled so much differently, not only just by, people in the community, but even by medical professionals sometimes have that kind of sense of bias that comes with them when they're treating individuals that happen to be experiencing suicidal thoughts and or depression versus how they may treat someone who's going to an oncologist and getting a chemo treatment and want to end their suffering in the same way, but for different reasons.
And I think that's a really, really important point. I mean, if you think about cancer or going to chemo, let's say you're going to an oncologist, there's scans, there's something visible about it, mm-hmm. and there's something socially acceptable about struggling with cancer, maybe because it's in no fault of my own. And then if we talk about someone that's dealing with a mood disorder, mental illness, or suicidality, there's this assumption that I'm somehow implicated in the illness, and that's a real challenge in terms of the stigma. And so it's invisible. I'm struggling, I'm suffering, I'm doing it alone, and I can't talk about it. So the more we can think about mental health and wellness through that same fairness that we do with physical, I think we're going to be farther down the road in terms of fighting stigma.
Yeah, and preventing death by suicides from happening, because they can get access earlier and aren't as afraid to talk to. They shouldn't just be able to have to talk to. I mean, I see a future one day where, we could offer screens around suicide risk in our pediatricians' offices, in our general practitioners' offices, really anywhere. Just like, I mean, I would love to see it like, in CVS where they used to, they may not have them anymore, but the blood pressure machines where you go in and like, and I mean, I'm even finding myself lighthearted by drawing this, using this as an example. But if we think about it, it really shouldn't be lightheartedness at all. Why wouldn't we be okay with having, like a computer screen where you could take a risk assessment or screen to see if you are at risk for suicide? No different than if you're at risk for hypertension. And I think the reason why, I kind of took a chuckle there was even my own bias there, going, gosh, I almost feel like that would be impossible to get to that destination point. And that makes me sad a bit. But at the same time, I'm glad we're talking about this, because it shouldn't, maybe there will be a day when we can really decrease the stigma associated mental health and suicide and depression, where it's like, of course it's there, right?
Yeah. We talk about this and we talk about that, and it's what we do, right? We talk about this as part of the lived experience for humans. And so I love your vision of being at CVS and having that, there's also the Dr. Scholl's foot thing, and you stand on it and it measures your feet and it gives you your assessment on how to walk and your weight distribution. It's pretty cool. And that's just for my feet. Think about for my soul, my suffering, myself. So
that would be ideal. Absolutely. And CVS, if you're listening, CHE and Sharp Mesa Vista will help you get there. Okay. So one last myth before we move on to some bigger questions, much broader questions. I'll say it that way. These are big, but the next one after this last myth is a broader question. So myth or fact, talking about suicide will lead to and encourage suicide.
That's a myth. I mean, as what we're already talking about, right? Mm-hmm. Talking about it makes it less dangerous. Talking about it makes it more acceptable. Talking about it makes it more understandable. Mm-hmm. And all of those hopefully reduce the stigma and shame that are currently associated. I do think one of the silver linings of the pandemic has been an okayness to talk about stress, anxiety, and sort of mental health. Like we've all been, everything has been disrupted and there's been this impact. And I do hope that, as we continue to talk about mental health, we can continue that conversation about suicide. And I think we will. And we're in the early stages, I think, of this. But we have to talk about it. So this podcast is a good example. Some of the work that we're doing with the council in San Diego is really trying to reduce stigma, and with the ultimate hope that we're increasing. And I know that this is really important to you, is about increasing access to care.
Absolutely.
That those that are hurting can get help. And that's eventually where we're gonna find ourselves. But it starts by having a conversation. And it's a hard conversation. It's
a conversation in our living rooms, right?
Correct.
At the restaurant, just at the park. It doesn't have to start in a mental health professional's office. It can end up there, which we would want, right? Is like once the conversation starts, it's this journey a person and their family or loved ones can take with them to get into a licensed mental health professional and talk through this. But what I hear from you and what I think the audience is hearing is that we all need to talk more about suicide for those very important reasons you brought up, because it makes us a healthier, not only individually, but collectively.
Yes.
Okay. Well, thank you for myth busting. Yes. I appreciate that. I think those are very important myths that we want to make sure people know. We can bust them now they're gone. Now I'm going to ask you the broader question. And this one's not an easy one, Mr. Westfall, and I apologize. So, maybe just don't take a bite of the whole pie. Don't expect for us, the listeners and me, don't expect for you to eat the whole pie. Maybe just a bite with this question. So, why do people die by suicide is the first question. Now, there's a second part to that question I'm going to tag on here. So why do people die by suicide? And audience members, hang on to your hats for a little bit. What is the main theoretical underpinning that mental health professionals rely upon when trying to understand someone's potential risk? So I'm going to let you chew on that for a second, Mr. Westfall. I want to tell the audience members, you're probably thinking to yourself, oh my gosh, Dr. Hoyt's getting into theoretical underpinning. I want to tune out. Listen, I think how Mr. Westfall is going to describe or answer this question is going to be really interesting for all of us because it's going to make a lot of sense. And I know him a little bit, so I probably know who he's going to pick and how he's going to talk about it. But I think it's so important for the audience to understand this a little bit because it does help us understand, this public health issue. Mm-hmm. So, okay, I hope I bought you some time to think about how you're going to respond.
Thank you. So why do people die by suicide? I'm going to give the unsatisfying answer of it depends, right? Why people die by suicide, it depends. What we can't do is say this is why everybody dies by suicide because it's a multifactorial phenomenon, right? Mm-hmm. There are so multiple pathways at play when someone finds themselves in that space. Mm-hmm. And so I think looking at the theories or at least the orientation, I think is a good starting place. And for me, it starts back with Emil Durkheim. And he was in the late 19th century, very famous sociologist. And he actually looked at the societal level and looking at what factors were at play. And he identified that social integration for people and moral regulation, the balance of that for people was really the driving force of why people died by suicide. And he wasn't concerned at all with the psychological, not even biological levels, like just societal. And that would be one of the criticisms of his work. But he was a frontier man looking at a complicated problem long ago. And so if you take that as a starting point, there's something in society that is at play. Earlier in the 20th century, Edwin Schneidman, who is the father of suicidology, he believed that it could be best understood through the psychological perspective. And what he had done is he identified this term psychache, and that as a profound and seemingly an unbearable level of suffering that people experience. And he had thought that this psychache that people experienced was paired with two other concepts. One was just a psychic energy to try to alleviate the stress. We think about that maybe when someone's really struggling with sleep and they're just restless and there's this inner energy.
Inner psychic tension almost.
He called it, his term was perturbation. But also there was something he called press, and that was an external pushing on the individual, like external demands. And so he said, you have psychache. You have this like unbearable suffering from
so
early
all
life
of those
experience.
Definitions you just described culminate into psychache.
Well, psychache is the basis of it, and then in addition to that, he described this level of energy, of activation, and coupled with external demands and stressors, and these together would then drive towards suicidal action. And I think an important piece, and I still think Schneidman's right. He identified that individuals have or an individual threshold is that we can only handle so much psychic, so much pain, and when that threshold is overtaken, then the person is suicidal.
I remember seeing a picture of a glass of water, and they were saying kind of like when someone is to think of the glass, like think of a person, the glass represents the person, right? And the water represents all of the things you just described, like biological, psychological, interpersonal, environmental, societal, all of these different components or factors. That's what the water is. And as the water just fills up, it eventually is going to not only just hit the edge of the rim of the glass, but it's going to spill over. And that just almost reminds me of what you're describing right now is like, it's like this spillover where someone just gets to this point and, if we can catch the glass halfway full, we might be able to like dump some of it out, right?
Right.
Like we don't need to get to first of all, we don't need to even get to the edge, let alone spill over. Hence preventable.
That's right.
Go ahead, please.
So I was going to say, Schneidman really, he was pivotal in placing this in the psychological, right, in this experience of the individual. And after that, in terms of like current understanding or theoretical orientations, there's a guy, Roy Baumeister, who really saw suicide as an escape from the self. And that escape from the self was an attempt to, again, alleviate that self-judgment, or what he defined as self-loathing, is that people who are suicidal, have high level of expectations of themselves and a keen awareness of their failing to meet those expectations. And that just fed the cycle of self-loathing. And so suicide then, and why people might die from Baumeister's perspective, is an escape from the self. And there's no other way to get out of that.
And maybe just to kind of dovetail, rewind back, like when you think about the myth, people who die by suicide are selfish and take the easy way out, right? We know that that's a myth. That's not a fact.
Yeah.
We know it's actually due to wanting to end their suffering. Maybe when people are kind of going through the literature and reading things like, what was the last theoretical person you just mentioned?
Roy Baumeister.
Yeah. Maybe they misinterpreted that. And that's how that myth, developed almost, is that, an escape from the self. But that doesn't mean it's the same of, that they're taking the easy way out, hence escape, right? Nomenclature, but more of escape from the self. And now we can see that in today's viewpoint is that's really, he's talking about suffering, escape from suffering. Would you agree with that?
I would. It's escape from one's own scrutiny. And there's nothing easy about scrutiny. In the hospital, what we have kind of taken as being our understanding or concept of suicide is the work of Thomas Joyner. And I know you're familiar with Thomas Joyner's work. And he's a psychologist and a suicidologist. And he and his team developed what's known as the interpersonal theory of suicide. And I do find... And
he lost his father by suicide, right?
He actually wrote a book, Why People Die by Suicide. I think it was in 2008. And that was a really big deal in terms of the research. But one of the things about Joyner, and I think what sets him apart from others, is that he really has considered not just what drives people to want to die by suicide, but also this other mechanism in terms of having the capacity to do so, and that behavioral side. And so for Thomas Joyner, what he's describing as to his answer as to why people die by suicide is that he has two concepts, and he believes that thwarted belongingness, which is a very odd phrase, is at work. And thwarted belongingness, we could understand that to be an utterance, I don't belong, or I don't fit in, I'm a misfit. It's those types of perspectives. And so if someone has that view of themselves and their environment, he also couples that with something called perceived burdensomeness. And that perceived burdensomeness is obviously that I'm a burden on others, and therefore I'm heavy. He also understands that as maybe not being a contributing member. I'm productive. And so for Joyner, if I'm a misfit, I don't belong, and I don't fit in the world, and I'm seeing myself as a burden and in some ways useless, those together create the conditions for the desire to die. And he doesn't stop there though, but he sees this as being one of the main pathways. And if we think about that from a compassionate perspective, right, and trying to help people not want to die, it's about it's about connection and purpose, maybe. And we want to think about who are those people that are not connected, or who could be, or at least their connection could be improved. So
right. Like how do we exercise those areas of their life? How do we build those muscles again for them?
Yes.
Whether that's, decreasing social isolation and increasing, community, right? Hence being able to reduce or diminish the perception that they don't belong or don't feel like they belong. In addition to, now that there may have value with that, there could be kind of this positive cascading effect that since they're out and they're doing things and they're being with others and they're engaged, that sense of perceived burdensomeness may not be as heavy. And you're saying if we can preventively work on those. Now I'm making it a little simpler than
No, it's
it
good.
needs to be, but if we can even work on those two areas, that could help reduce the desire to want to die. That
Correct.
could be a way to help, and that's what Joyner posits.
Yeah.
Am I getting what you're laying down?
That's it.
All right.
So that's the first part, is that there's the desire to die. And what I think is unique to Joyner is this idea that with that capacity, the desire to die, there's this other side of it, and that would be the acquired capability to the ability to enact lethal self-injury. And I think of that as jumping over the survival instinct. We have the survival instinct to survive, and it requires something to jump over that, to disregard that. And his perspective is that happens for people through habituation, where scary things become less scary. That to be able to die by suicide, I'd have to lose some fear associated with that.
Right. Like the thoughts itself can help create like this. Imagine this kind of fantasy is not the right word, but in the psychology world, we use it just to describe someone's mental state and what's happening in their minds. But so this kind of fantasy that, they see themselves dying, it's almost like this mental rehearsal. Yes. And that it's constant, coupled with perceived burdensomeness, thwarted belongingness, desire to die. This acquired capacity happens where we can override our ancestral threshold, or ancestral being, it's been passed down for thousands and thousands of years that we're to thrive and survive. That's what our ancestors gave us. So you're saying there's like this way where a person who is in this state can eventually jump over that piece around, that ancestral inheritance piece to want to thrive and survive, pass by it, because those thoughts have been rehearsed so much where there's this sense of repetition where it's just not taboo anymore. It's not scary for them to think about it.
And painful things can become less painful.
Right.
It's another way that the habituation might happen. So,
but not in a way where it's positive. It's more in a way of like numbing. A numbing. Yep. Yes. You took the words out of my mouth.
Yes.
Okay.
So an example would be someone who might have the desire to die, and they're contemplating jumping from a high location. They might go there and check it out and then leave, but not jump. And that would, from Joyner's view, that would be an example of, in some way, habituating to this, and the fear is reduced, et cetera.
And overriding that
the survival instinct. So it's a really important piece. And I would say, earlier in my clinical work, without the awareness of Joyner, it was really thinking about suicide, or thinking about what he's describing as the desire to die, and not really having this other awareness that there's this mechanism at play. So we want to think about that when we think about suicide. And I think Joyner really provides that piece, like for people who he defines, direct or indirect pathways, and going to a high place is an important thing to note.
I agree with you, because it also, as a practicing psychologist, when I'm treating clients that are potentially at risk or are at risk, it's helpful for me to conceptualize in that way to, take action with them. Right? It's almost like the theory lifts itself off the page and into the office. And I can make some action around it. I can start to examine and ask questions about perceived burdensomeness, or thwarted belonging, or habituation around thoughts, right? And I can hence take that theoretical perspective and make it real, and make it something between me and my client that can be really collaborative, helpful, and hopeful.
Yes, that would be the hope. Right. And that to me is where the meaning, that's the significance of theory, right? Is that it helps provide some flesh, and it helps, it makes sense of what people are saying and dealing with. So I think
it's like the gap is, it's like the gap is reduced, right? Like the research gap to practice gap with Joyner's theory, it's kind of that gap has shrunk a bit. It's not the Grand Canyon anymore.
It's still there though,
yes, it is.
In terms of research, it's hard to research suicide, and
yes,
for obvious reasons. But I think I think Joiner's got us way far down the river. So,
and more to come, to come.
For sure. I'm
So
hopeful.
my next question for you. So
Yes.
we know that suicide, like other human behaviors, and what you just mentioned, has no single determining cause. Instead, you had mentioned too, suicide occurs in response to multiple factors like biological, psychological, environmental, societal, and that they interact with one another often over time. So knowing that we know there's no determining cause, let me ask you a question about risk. We've been talking about factors, but let's talk about risk factors and also something that the audience may or may not know a lot about, protective factors. Can you tell us why they're important to understand and really what they are? What is a risk factor versus a protective factor?
Sure. So when we think about risk factors, we're thinking about modifiable risk factors and non-modifiable risk factors. And so just to kind of clarify that, a modifiable risk factor is something that can change, and a non-modifiable is static. And
okay.
So for an example,
it
cannot change. So if we think about someone's risk factors, what I'm trying to understand or see is how at risk someone might be for suicidal behavior. And obviously through clinical assessment, asking questions, trying to get a good understanding of someone's history. So for an example, if someone has a family history of suicide, that's a non-modifiable risk factor that cannot be changed. That is a static factor in my equation of someone's risk.
Just as much as like my age can't be changed.
Your age cannot be changed.
Even though I really would like to.
Yes. Correct. Yeah. Right.
Got it. Okay.
So age can't be, gender can, in terms of that. So mood disorders is something that we think about, mental illness, history of those. We could argue if that's modifiable or non-modifiable based on intervention and medication. Substance use is a risk factor, and I would hope that would always be a modifiable risk factor.
Of course.
There are certain health conditions. People who struggle with pain have a good amount of depression as a risk with that. And so we want to think about pain, anything that might lead someone to feeling trapped and hopeless. History of violence or victimization or trauma, abuse. These are risk factors that we want to think about. And then what we don't know a lot about, and yet there's still some research happening, is in terms of the genetic, biological structure behind or supporting suicide risk.
I'm actually going to have hopefully another guest on that's doing a lot of research on that. So we will save that portion for another day. But absolutely, there's a lot coming out around that.
So there are also, we could describe it as interpersonal factors, risk factors. So for many people, conflict, right, breakdown of relationships is a risk factor that leads people to wanting to die. Or violent relationships. Like that's something that we'd want to look at and assess the status or quality of the relationships that people are having. And in some sense, that's full circle back to Durkheim and this idea of our social connection. So financial stress can be a modifiable risk factor. Recent loss. Work is a profound stress. The pandemic, we thought that there was going to be more suicide, and it turned out resulted in lower numbers of suicide, which I think we're still going to have to make sense of that in the years to come. What worked in the pandemic, and hopefully we can replicate that. More connection, maybe less stress.
Well, what I'm hearing from you, like what I'm reading in between the lines, and here I am carrying the torch of hope again. What I'm hearing is that there's almost like, as much as it's important to understand static risk factors, just because we know that they're risk factors, we don't ignore them, but they don't change, like our age, for example, or a history. We can't go back in time and, try to change history. But the modifiable ones are the ones where there is some opportunity to change those circumstances, like around like lack of social support, for example, or work stress. Like maybe there's an opportunity to get a new job. And if new job isn't something that's feasible, maybe there's an opportunity to talk to your supervisor or HR or something that could help reduce some of those stressors that could be modifiable and then hence help reduce the risk. Am I right?
You're sounding like a psychologist. Yeah. So identifying the areas where where we can intervene, right? So we want to capture all of the risk factors, and then we know where to focus to then reduce the overall risk.
Perfect. Yeah. Now tell us a little bit about protective factors.
So protective factors are those just like we would think about those circumstances or events or qualities that would lower or protect us against a risk for suicide or buffer us against the risk. And so, being able to let me think about how to say this, having effective coping strategies, having a pretty regulated emotional experience. Sometimes people will identify religious belief or an objection to suicide as being a protective factor. Fear of death is one that I've heard pretty often. Obligation to other people, responsibility for pets or for family members or friends or to the community is a really important protective factor for many people.
And what about reduced access to lethal means?
Well, that to me is one of our biggest opportunities.
That's why I brought it up. I knew you would appreciate that.
So, reducing access to lethal means is going to be it's a protective factor at a societal level, at a yes,
community level,
and
an individual
and family,
level,
individual level. Yeah.
Absolutely. So you're saying that protective factors can help counter or buffer against a number of risk factors sometimes, but it's not like one for one. I don't want the audience to think of that like, oh, okay, well, I have this person has 10 protective risk factors and only 8, or 10 protective factors and only 8 risk factors. Therefore, they should be okay. We don't want to think of it that way, right?
Correct.
Okay.
Yeah, they're not one for one, because someone could have 15, risk factors and yet a very fervent religious belief, and that religious belief is sufficient, and that's all they need.
Or the other way around.
They have one risk factor and a lot of protective, but that risk factor is significant.
Absolutely. But it's important for us as when we're working with people that are struggling with this, again, going back to why we want to think about this or conceptualize it as mental health professionals, is to really look at what we can encourage to be modifiable and opportunities to reduce that risk. That makes a lot of sense. Okay, another question for you. We've got a couple more because I know we're running out of time, and we could probably have 5 podcasts about suicide prevention, but I think this is important for the audience too. So one of the main contributors to suicide is, a person's experience of hopelessness and burdensomeness. We talked about this, and isolation and to the belief that there's no end to their suffering. Right. And we know that as our loved ones, that this does happen to us. We read the stats. It doesn't exist in a vacuum. So many of our loved ones are going to face crisis at one point in their time, are going to feel suicidal, and may be unsure and those loved ones may be unsure if they're at risk of hurting themselves. So if I'm, worried about, well, let's say we've been colleagues for a long time, Charles. Let's say I'm worried about you. What do I want to look for? What are the risk factors and warning signs for someone who may be at a high risk to die by suicide? What do I look out for in you? Yeah. To help you.
I think what you're looking for are changes in what I'm saying and changes in what I'm doing. And maybe it's changes in what I'm not saying and not doing. So noticing, which implies that you know me, and it implies that you know what my, let's say, usual presentation is. And so that's the starting point, is like, let's look at changes. And when we look at changes, we've been lucky enough to be given the mnemonic is path warm. And this is an opportunity to really think about warning signs in a intentional way. It's not exhaustive, but it's pretty comprehensive. So if you think of the risk factors as being like the base, then there's these warning signs that might be circumstantial. It might be stressors in one's life that are leading to more and more and more warning signs. And so if you hear me or you see me, if I'm communicating in some way, any type of suicidal ideation,
take it seriously.
Yeah.
You're not doing it for attention.
But even if I am doing it for attention, we want to take it seriously that I need that attention. And,
right. Even better said.
So we want to be really careful about dismissing one's ideation for the reason of, oh, it's just attention seeking. That's what they do. I think that creates a dynamic of, or perhaps it creates a dynamic of people upping the ante for more and more attention and therefore riskier behavior. So you want to listen for any type of wishing to die, better off dead kind of verbiage. You'd also want to probably look at my substance use. If I don't use substance, but then I start using substances, or I use substance and I'm just drinking a lot more, that's going to be another warning sign. And while we don't see suicide as being impulsive, that drinking can definitely advance my
impulsivity,
my impulsivity and my ability to jump over that survival instinct.
Right.
So
the
we want to think about
habituation
that.
piece. You're number when you're drinking, right? Or using some substance altered.
So
when your
mood's
that. Altered.
Yeah. Purposelessness, listening for that, some hopelessness, increased anxiety. And I think sleep is part of that. We want to always look at and monitor someone's sleep. If they're not sleeping, everything gets worse. And if everything gets worse and you're not sleeping and you're at night alone and it's dark and quiet, you can think of that as being the vulnerability for things to get worse quickly. So we want to observe and be aware of people's sleep and anxiety. For me, the concept of being trapped is a really important one. I think of trapped as being an experience that people can't sustain long, and I think suicide can then become an option to alleviate that feeling trapped. So trapped in a relationship, trapped in a job. Trapped in a location, trapped
in all of them.
Trapped in poverty, trapped in just feeling so trapped, because then it leads to that hopelessness that this isn't going to change and I can't do anything about it. And it's coupled with some powerlessness, and together that triad's pretty dangerous.
Right.
So
I want to look for that. I want to look for those type of statements too.
That's what I personally think is a big deal, is feeling trapped.
I agree with you, actually.
Withdrawal, right? So if I'm disconnecting, if I'm withdrawing from you, if I'm disengaging, that's a really big deal, because again, isolation makes things worse.
Absolutely.
So, and then, irritability and anger, if I start getting more and more, like my tolerance for frustration is lowered, that's probably a good indicator that I'm not doing well. And then recklessness. So if I'm doing things that I normally wouldn't, I'm driving fast, I don't care about consequences, that's a good indication that I'm also, not well. And then lastly, mood swings. We want to think about mood swings and lability and how people are responding to stress in their life. Now, it doesn't mean that if somebody's dealing with some of this, that they're suicidal. This is simply just warning signs that we want to be aware of. We don't want to be asleep at the wheel. So it doesn't mean that these aren't causal, but these are just indicators, and we want to see them as such.
And that's helpful for us to understand. So if you or a loved one if you or your loved one, because you can also see it sometimes in yourself, or you've noticed these things happening for you, or you've noticed it for your loved one, don't wait. There is help. Again, you can text 988. You can go to your local hospital. If you're in San Diego, you can go to Sharp Mesa Vista. If you want outpatient, you can go to CHE. There's so many new avenues for access to get professional help. I'd like to just repeat that mnemonic again to the audience. It's called Is Path Warm? And Mr. Charles Westfall broke that down for us as risk factors and warning signs that a loved one can use to see if they may, be at risk to harm themselves. That is typically, if you Google it, Is Path Warm, all capitals, you'll find a lot of great pathways and links. But it was created by the American Association of Suicidology to help therapists and the general public remember that these are warning signs related to suicide. So thank you for bringing up the mnemonic. It's very important for all of us to understand and be able to access and examine for not only ourselves, but for our loved ones. So this question's going to, I think, lead nicely in for you. So if we do this, Is Path Warm, right? And we go, oh, yep. Oh gosh. Like, oh, I've noticed this. I've noticed that. I've noticed this. And I'm worried that, you're suicidal. What should I do? How do I get him access? What do I do?
Well, it starts with the conversation. And I think all of this requires courage. I think it requires courage to talk about suicide. It requires courage to talk about mental health. It requires courage to talk about something that you maybe don't feel comfortable talking about. It's awkward, it's messy. And so the first task is to just basically initiate a messy conversation. And your role is to be supportive of me because I'm hurting.
Right.
That's it. Your role is to be supportive, not to judge me. You're not trying to fix it for me. This is my experience. If you start problem solving for me and you're in that problem solving mode, the consequence might be is that you're minimizing what's happening for me. And if you're minimizing what's happening for me, my response then would be to probably shut down and disengage from you and keep you out, which then only worsens my experience. So I think, so the first part is you're being supportive, and I think giving yourself permission to enter it, that there's not a perfect way to talk about suicide. I think staying curious is always important, asking a lot of questions and really listening to the answer, which means being present to someone. And it might stir up your own anxiety and your own fear, and depending on the relationship. And I think it's important just to acknowledge that
make room for it. It's okay.
Correct.
It is scary. Yeah.
And it's vulnerable. And it's a hard topic. And there's probably few things more personal to the individual than suicidal thinking.
Right.
This is a really intimate experience. So don't try to fix it. And I think avoiding giving advice is, again, anything that would minimize someone's experience, I think is something we want to do our best to avoid.
Right. We want to keep them talking. And so if we start giving advice, that's the opposite. We're talking, they're not. Right?
Yes. Well, there's two goals, right? The first goal is to let them know that you care and that you're there. And the second part would be hopefully to help them get help if they need help. And so your help in being present might be helping them coordinate or schedule a session with a therapist. Maybe it's bringing food to them and supporting them in that way, or cleaning up the house if that's what would be helpful, like lightening their load.
Absolutely.
And I think it's really important to say that if the individual's in a crisis and you're talking about this, you're always needing to think about safety first. And so that might be going to the nearest emergency room, calling 911. If there's really safety issues happening in the conversation, so that individual can get a clinical assessment. So kind of depends, on the specifics, but we want to be present, we want to be helpful, and help them get access to care.
Absolutely. And for our audience listeners, Mr. Westfall really summarized what to do and how to do it in the best way. But if you want to read more about this, go to www.NAMI, National Alliance on Mental Illness.org, www.NAMI.org. And they have a lot of great articles that can teach us and the public about how to talk to someone who may be suicidal and how to help them and how to be compassionate, and really just walk you through what Charles just mentioned to us. So again, www.nami.org. Listen, Mr. Westfall, we are coming up almost at time, and there are obviously, I have at least 3 or 4 more questions for you, but I know we're not going to have the time. We should probably definitely invite you back so that we can, again, engage in such an important topic. But with that said, I wanted to give you an opportunity to either share some last thoughts or, something that you really wanted to mention and teach the audience, or just discuss, before we finish our podcast today.
Okay. No, I really thank you for the time. It's really nice to be with you and talk about this important topic. I would say when we talk about suicide prevention, I think it does start again with the conversation, and it's going to take all of us to do this. This is a slow moving machine, and I think we're going to get there. But I think number one, my takeaway would be is that we've got to reduce stigma and the shame attached to mental health and to suicide. And until that happens, I think we're going to continue to struggle. So it takes courage. The second one is around reducing access to lethal means. That's something that we can do today. I mean, that's something, if you are listening and you are a gun owner, as an example, making sure that those guns are securely locked up. And if you're struggling with mental health, crisis, or even a mental health struggle, ensuring that someone else has access to that and not you is really important. We know that creating a delay in access results in fewer deaths. And this is
Yes.
just evident. So being able to think about how do we reduce access to lethal means is really, really, really a great opportunity.
And you're talking about means restrictions.
Means restrictions. So, that means making sure that you don't have a bunch of pills that someone could have access
Stockpiling.
to. Stockpiling pills. So there's a lot around that. And that's, I think, a current spot for research to continue and improve. And it's a lot of education.
Listeners can do too. You can do that now is like, let me make sure, like you said, if I am a gun owner, I'll make sure that my guns are locked up safely, that there isn't this immediate access, that if we can restrict the means to get access to the guns, for example, we can then delay the potentiality from someone dying by suicide.
Yes.
Same with stockpiling medications. If someone doesn't have access to, 15 different prescriptions anymore, that can delay it. And what we're creating is a pause for them. We're kind of facilitating a structured pause for them to say, hold on, let me see if I can get you the help. But without that delay, you're saying there is an increase or rise of death by suicides. But with that delay, it decreases. Did I understand that correctly?
That is correct.
Okay.
Correct.
It's so important. Was there any other final thoughts that you wanted to share with the audience?
I think it's important what you're doing. So thank you for doing this podcast. And that's all I'll say. Thank you.
Well, thank you, Charles. And you are doing some great work too. To the audience members out there, to their loved ones, we want, I think on behalf of Mr. Westfall and myself, we really want to impress upon you that there is always hope. If you or someone you know is experiencing mental health symptoms, especially suicide, hear our voice. We need you. Please stay and live. Courage can be found all around you while you cope with your stress and seek out treatment. We want to just say for all of those that are no longer with us, please let their moments of silence continue to be heard loud and clear. No one will be alone or forgotten. And as long as together we can promote awareness and hope. I'd like to also say that to our listeners again and their loved ones, please remember to hold on to hope. There is always help. If you or someone you know is experiencing mental health, suicide, or substance use crisis or emotional distress, reach out 24/7 to the 988 Suicide and Crisis Lifeline. You can dial it or text it 988. And you will be connected to a trained crisis counselor. We have been talking to Mr. Charles Westfall, licensed marriage family therapist and clinical administrator at Sharp Mesa Vista Hospital. Charles, before we sign off, where can people learn more about your organization or yourself?
Sharp.com. You can Google search for Sharp Mesa Vista Hospital specifically if you're in the San Diego area. You can call our hospital, 858-360-8044. If you're interested in the San Diego County Suicide Prevention Council, you can also search for that. And it's a volunteer organization and we're doing great work. So join us.
Fantastic. Thank you again,
Thank you,
Mr.
Hoyt.
Westfall. This is CHE's Ready to Talk, Ready to Listen.
Thanks for joining us in this episode of Ready to Talk, Ready to Listen, all things mental health. Click to subscribe to our podcast on iTunes or Google Play. Until next time.